Hello and welcome to Global Health TV. In the show today, we'll be debating effective, low-cost interventions for diabetes. Around 422 million people worldwide have diabetes, and 1.5 million deaths each year are directly attributed to diabetes, according to the World Health Organization. Both the number of cases and the prevalence of diabetes have been steadily increasing over the past few decades. At the American Diabetes Association scientific meeting in San Diego, California, experts from around the world gather to explore the latest research into diabetes treatment and care to tackle this growing burden of disease. My colleague, Audrey Godfrey, is joined by Dr. Sridharan Raghavan from the University of Colorado and Dr. Lisa Staimez from Emory University to debate whether diabetes is best prevented through a public health approach or through personalised medicine.
We are asking the question today, where lies the key to type 2 diabetes prevention? Is it in population health or personalized medicine? Here to debate that very topic is Dr. Sridharan Raghavan and Dr. Lisa Staimez. Thank you both for your time this morning.
Thank you for having us.
Dr. Staimez, I want to get started with you. Let's set the stage. How do you define population health versus personalized medicine?
Population health and public health is what we do as a society to protect the health of neighborhoods, communities, and larger populations. Personalized medicine, in contrast, has more to do with the patient or the individual and what we can do to set them up for good health. And often that's referring more to a clinician-patient interaction.
All right, so to make this a proper debate, let's set our point of views. You do believe that public health efforts are the way forward.
That's correct.
How come?
Well, if you think about what's really driving health problems, and diabetes is a huge problem, the prevention of type 2 diabetes is really going to require us to address those problems. What are they? It stems with problems from the individual level, but also includes problems related to interpersonal relationships, to the context in which the individual lives in, the way in which sectors influence behavior. That is not only the health sector, but can be other things like transportation, land use, etc. And moreover, even the society and the norms, the cultural norms around how we act, behave, live, our abilities to choose certain behaviors, all of these multi-level factors are really influencing disease risk. And so we need to target all of that at one time. That's why I think public health is the way to go.
And Dr. Raghavan, on the flip side of things, you believe that a more personalized approach might be the ticket?
Yeah, I think at the base of everything that Dr. Staimez said is the individual, and many of the things that prevent diabetes require individual behavior change, whether that's taking a medicine, changing lifestyle factors, and that's where we're really failing at diabetes prevention right now, I feel like, is motivating folks to adopt healthful change behavior, and that really is where we need to improve our sort of approach to personalizing, providing options, convincing patients where they are to adopt the changes that are necessary.
To his point, don't you believe that there is some sort of personal responsibility that has to factor in?
Absolutely. And a public health approach doesn't really negate or say that the individual doesn't have a role. However, if we don't address these broader societal factors, we won't really be so successful. Part of what influences the individual behavior is those societal factors. And so we really need to account for the social determinants of health that is driving health and disease, and really account for that as we plan for the most effective strategies to prevent diabetes.
Dr. Raghavan, without the public health component, wouldn't we be setting an individual up for failure, do you think?
That's a tough question. I think we have to also think about what's available now. And so if we wait for societal change, public health interventions to take place, then we still have a problem of what do we do right now with the people at risk right now. And right now we have approaches that require individual buy-in. And so I don't think they're mutually exclusive, but at the moment, when we have personalized strategies, we have multiple options available for a person. When we talk to patients in the clinical context, we have to figure out what they're able to do and why they can't do other things, and then tailor the appropriate approach to them. We can't wait for neighborhoods to change, in the next 10 years. That should happen simultaneously, but right now we have a problem that can be addressed at the individual level.
Final question for you both. Is there a path forward where both the public health component and personalized medicine can work in tandem. The dream goal, I guess.
100%. I think that if we acknowledge the limitations on both ends and address those in developing solutions comprehensively and integratively, I think we can reach that point. Specifically, I would say that in the limitations of personalized medicine, as relying on data and machine learning and artificial intelligence, 90% of people who have prediabetes don't even know they have prediabetes. So they may not be interfacing with healthcare. So we need to acknowledge that we don't necessarily have the data needed to drive algorithms. Secondly, of the data that we have, we need to make sure that they are transparent and responsible in those techniques, because we don't want to worsen health disparities. And that can happen if machine learning is driving clinical decision-making in black box techniques.
Dr. Raghavan, final thoughts to you. Is there a way where both worlds can come together?
Yeah, I mean, I don't think anything we've said is mutually exclusive. I think this contrast is probably more a result of individual priorities and personal preference than anything else. And I think there's plenty of opportunities for growth in both areas, and they're both necessary.
Wonderful. Thank you both so much for your perspectives today. Thank you for your time.
Thank you so much for having us.
Now, gestational diabetes is high blood sugar or glucose that develops during pregnancy and usually disappears after giving birth. But gestational diabetes can cause health problems for mothers and babies. There is evidence to suggest a low-carb diet may be a treatment for the condition. My colleague Audrey Godfrey is joined by Dr. Amy Valent from Oregon Health and Science University and Dr. Teri Hernandez from the University of Colorado to debate the issue at the American Diabetes Association scientific sessions.
The concept of going low carb during pregnancy to treat gestational diabetes is one that's been hotly contested. And here to do just that is Dr. Amy Valent and Dr. Teri Hernandez. Thanks for your time this morning.
Thanks for inviting us. Thank you.
All right, let's get started with where this concept for a low carb diet as a treatment option for gestational diabetes even came from.
Yeah, it's a really great question, and sometimes we can get our answers from history. So over the last 100 years of understanding diabetes in general, let alone in pregnancy, has kind of shown us that prior to the era of insulin, we couldn't even have pregnancies for people that had diabetes. And then we realized that within the era of insulin, that not only does blood sugars save people's lives while they're pregnant, but also by controlling blood sugars that we're able to actually make differences in perinatal outcomes. So from that, obviously, others, experts in the field, up until the last probably 50 years or so, have kind of demonstrated that there's a correlation with carb consumption and blood sugars in pregnancy, particularly after meals based on pregnancy physiology. And so based on that, we've kind of evolved into going more towards lower carb intakes during pregnancy for treating diabetes in general.
Dr. Hernandez, you are not in favor of a low-carb diet to treat gestational diabetes. Is that because you don't believe that there's kind of a one-size-fits-all nutrition approach for patients?
My position on this is really in favor of creating options for women, and the idea that maybe low-carb diets are not the only way to treat gestational diabetes with nutrition therapy. And so if you talk to women and you really understand their experience, what women say is that it heightens their anxiety to try to cut carbs. And it's very hard to change your diet so late in pregnancy when you've already been pregnant for, 2 trimesters heading into that last trimester. So if there are ways that we can customize the meal plans for them, and maybe it doesn't need to be low carb, depending on their metabolism and their response, then I'm in favor of maybe more options and a broader flexibility in carbohydrate content for gestational diabetes.
That makes a lot of sense. Dr. Valent, though, is there data to back up a low-carb diet for those with gestational diabetes and the treatment of it?
Yeah, it's a great question. From specifically looking at gestational diabetes and low carbs, there are more data that are coming out that people are looking at differences in carbohydrate content. And I think the challenge is that these studies are really small, and looking at specific outcomes is a really big challenge when you have small studies. And so although there are some, at least it's not showing for what data is available is that it's harmful per se when we look at pregnancy outcomes, but the data isn't robust.
That's so fascinating that you said it might not be harmful. It leads me right into my next question. Do you believe that there could be some negative side effects for women who adopt a low-carb diet during pregnancy?
I think the best way to frame that question is, what are the potential concerns or questions about going below, low carb, meaning either 40% of total calories or 175 grams per day, which, by the way, are two very different questions. But the relevant considerations, I think, are the following. First, mother's physiology and how it's tightly integrated with the baby's physiology, the fetal physiology, really depends on the idea that mother's glucose needs to be higher than the baby's.
Okay.
So if mothers, theoretically, cut enough carbohydrate and don't take in enough glucose, that gradient that ensures the baby gets the right energy from mother's glucose could be jeopardized. The second consideration is exposure to ketones. So as carbohydrate intake is further reduced, across kind of a continuum, mothers can become ketotic. And in pregnancy, they're prone to that anyway. And so there are some concerns that could jeopardize the baby's intellectual development and development of the brain. And then two other quick considerations are micronutrient deficiency, which is actually very common with carb restriction and with lower energy intake that tends to go with carb restriction. So I just think that we need to be very intentional if women are on a lower carbohydrate diet option to make sure that their micronutrients are supplemented. And then the fourth, this would be the fourth, is exposure to higher fat. So with reduced carbohydrate typically comes with higher fat intake. And so I, with others, have raised questions about if that heightens maternal insulin resistance and sort of increases all nutrient overload to the baby. And I think that we have more work to do, but those would be the four big considerations.
Okay. Dr. Valent, final question goes to you. We've been talking about a low-carb diet as a method to treat those with gestational diabetes already. For those who do not have it and might be considering adopting a low-carb diet as a preventative measure, what do you say?
The data doesn't really support low carbohydrate for a preventative measure. But I will say also, with full disclosure, that we don't have a lot of studies that are focused on prevention. Certainly from lifestyle studies, there is a lot of heterogeneity to those types of studies. Nutrition studies are really hard to do. And at least for now, it doesn't seem to be that low carb potentially would be preventative.
Okay.
But I think it's also part of the pathologic process that we need to have a better understanding of the natural process.
Sounds like there's still a lot of research yet to be done.
There is.
Can we come to an agreement on that?
Yes.
All right.
We agree.
Absolutely. Ladies, thank you both so much for your time today, and thank you for both of your perspectives. Appreciate it.
Thank you so much.
Thank you.
That's all for this episode of Global Health TV. For more shows, do take a look at our website, globalhealthtv.com, where you can also find episodes of our new podcast, The Global Health Clinic. The podcast is also available from wherever you get your podcasts, so do have a listen. So until next time, it's goodbye.